neurosurgery that I think is really exciting and really, really cool. And it has to do with spatial computing. And I think I've talked probably about spatial computing with you guys in the past. Um, but things have evolved a little bit. And so I think it's a really great time um, to go back over this. And so let's see. Am I in presenter view here? One sec.
Now you are, yes.
Great. All right. So neurosurgery has always been a spatial, you know, practice. It started with X-rays, which looked at the whole body in 2 dimensions, then CAT scans and MRIs, which even though they showed you three-dimensional things, they did it in 2D formats on a screen. Navigation allowed us to start to manipulate this and look around, but even again, that 3D image was presented in 2 dimensions on a screen. We got advanced imaging techniques. We brought augmented reality into the operating room. And finally, we were able to walk around our anatomy and interact with it and make it bigger. We're continuing to push in those regions. And so extended reality or augmented reality, whatever you want to call it, mixed reality, really was kind of the initial step for training and simulation. We could see what we were doing beforehand. We could preoperatively plan things. We could show this to patients and, help patients actually understand what it is they were dealing with, which is a major, major win when you're talking about complex neurosurgical issues that, people don't have a lot of insight into. And when it comes to training, this is actually hugely important because it's very high fidelity. It's built on scans that we use. And the studies have shown throughout general surgery, ENT, orthopedics that extended reality-based training improves skills 30 to 50% faster than if you're just doing it when you're doing it. And it has to do with repetition and rehearsal for the most part. But again, when we looked at this, if you had never done it, or you had never put one of these systems on, you saw some benefit, but until you actually put the machine on and you played with it, that's when you realize like, oh wait, there's like an easy passive learning component to this. And we deal with that with the augmented reality constantly. I joke about it where I just have to rotate the head around once in 3D as opposed to on an MRI on my screen. And it's almost like I've rehearsed the surgery already because I've seen it anatomically where it is, and humans are just very good at remembering that kind of stuff. So while the extended reality revolution was going on, we all know that large language models have come up. And these have changed, really how we think. In the past, we needed to find knowledge in, literature reviews, search engines. All of a sudden, we had an immediate answer that was accessible. It's contextual. We can interpret it. It's read in a nice way. And what that does is it reduces our cognitive load. And cognitive load is a really interesting concept when you think about it. It's like in Tetris. When you're playing Tetris and the piece shows up at the top of your screen, you can rotate that piece in your mind mentally, but it's a lot easier to just tap that button until it fits the hole. And that's an epistemic tool. Just do that until you have to reduce the actual rotation in your brain. It makes you think faster, makes you move faster. And this is what AI has done for us. And spatial computing, oh, actually, wait, this is a great slide because of these little icons. So if you think, you guys don't even know this because you're all children. But we've interacted with computers via these little icons over the past, 50 years or so. From the keyboard, the mouse was a huge innovation, the touch screen, our laptops, our iPads. But the spatial computing is the next step in this. And that's because when we interact with the world, we don't talk at the world, we look at the world. And in medicine, we sight and vision and understanding relationships is really, truly, a huge component. Um, but when you build these things together, what you're able to do is take that 3D augmented reality now and input information on it, just like a GPS system, where now I don't have just a map in my hand that I have to, or the direction someone told me. I know that there's a flat tire in the middle of the road, or there's a car with a flat tire. I know that there's police reported ahead. I know that there's what was the thing on it this week? There's 100 Wendy's in the near vicinity. Um, and so I talk about this as terms of adding layers to what we can do. And so this is now that same scan or a different, I think it's a different scan, but I've added the Connectomics imaging, which is looking at actual brain network architecture onto the brain. So when I'm planning my approach now, I'm planning around these really critical networks. And I can see them in space again, and I understand that immediate kind of rehearsal of what it is we're going to go in and we're going to do. You can see the fidelity of it's pretty amazing. It's complex, but you get the hang of it really, really quickly. So we take that down, we can bring that into the operating room because then these are computers that are, essentially attached to your face. And so here's our exoscope output displayed in just one virtual screen. None of these screens are actually there. And then we can see the three-dimensional volume as well as the screen. And, um, we can actually operate like this with all this information ready to us. We can use the cameras on these systems for registration that this is like a Snapchat filter, putting your MRI attached to your face with millimeter accuracy. The third is similar again, rapid registration, reducing the cognitive load. All you're doing is looking at this face, and the computer is able to do that work for you. And then you have all this information at your fingertips. And that's in the operating room, but we can also bring this out into the ICU, and I'm going to show you that in a minute. But the bottom line is in the past, we had to translate all this information. We had to take the MRI and the CT from looking at it in our office into the operating room. And we had to say, uh, the left side is the right side of the screen, because that's what happens when you look at an MRI. And that artery looks like it's maybe diving a little bit to the left around this tumor on this cut. And then on the other cut, it skirts the other way. Well, we don't have to do that anymore. That's stuff that's going to be made available to us. And so the surgeon gets to be, instead of a translator, a decision maker in this big integrated system, which I think is a much better role. And it's changing the interface of whatever you interact with. This is placing a ventricular drain in the ICU. And you can see there's the instructions on how to do it on the left. There is the component that shows you where your instruments are. It's instrument tracking immediately. You can see the depth of how far you have to pass your drain and where your targeting is based on that little bullseye there. Um, and so this stuff all of a sudden now hopefully is going to have meaningful changes in outcomes and things like that. I'm sorry, there's a lot of noises. I get about 1,000 emails every morning. So again, I told you I would keep this kind of short, but the question is, well, what comes next with this, right? Surgically, we're good at anatomy. We're getting better at treating certain diseases. Our technology can definitely get better. And can we incorporate the AI and spatial computing with the visualization so that we get to a point where you just point to tissue with an instrument and you say, what is this? And the Apple Vision Pro tells you, says that's the optic nerve. Or if you're unsure, which nerve is this? And it tells you that's the third nerve. Or in more difficult cases, when you're just in brain, which is like I've said this before, like tofu, and you say, where am I relevant to the cortical spinal tract, which is a region that we don't want to hit, and the machine learning can lay it on the brain for you in an augmented reality way and show you, um, or just simple things. Can you say zoom in, and the microscope does because it's listening to you. Um, and so the operating room in the near future has this AI generative component, this robotic component that I think we're getting to. And I'm going to show you a picture of that, um, as well as this kind of spatial component, which is going to serve as the integration for the whole thing. So this is some video of the exoscope output in the Apple Vision Pro. What I'm looking at here is not really there. It's all an augmented reality screen in high def 3D 4K. And there's a little bit of a lag you can see, but the fidelity is really, really good and getting better. That's the most important thing. And that's why I call this the future of neurosurgery. And then moving on here, bringing in, like I said, the augmented reality overlay. That's the transverse sigmoid sinus overlaid on my image while I'm operating. So this is, again, a virtual screen with a virtual image laid on the virtual screen that tells me where there's a critical vein, that if I bite into that, I cause major problems. Um, and you can do this at a much more granular level now also, where this is the facial nerve that's been highlighted on a retrosigmoid approach, which is an extremely, I mean, we're talking about a 2 to 3 millimeter nerve at the skull base, and you're able to follow its track so you can find it. Um, and, hopefully we're not there yet, but hopefully label it independently as well. So I think just a truly exciting time for spatial computing and neurosurgery. And again, the idea here is just real-time, dynamic. You can interact with it, intraoperative guidance to reduce that cognitive load. Let us, um, be not just interpreters, to let us make actual decisions based on meaningful information. Um, this is the difficulty with this, and it's beyond the scope of what we do here, because I think what I like BrainTurns to do is really to like keep people inspired. Um, but whenever you're bringing in technology, you have to worry about, well, who's going to pay for it and why are they going to pay for it? And for all of you who are, having all these brilliant ideas probably daily of how you're going to change the world, this is the root of everything, unfortunately. And so what does success look like? Is it better training? Is it better imaging? Is it certain cases where this is really useful? Is it the patient experience? How does it generate cost reduction? And that's how you make things happen. And I don't have the answer to that yet, so we're working on it. But anyway, short discussion on that. I think it's a really exciting topic. It's a really cool concept. And we've got about 15 minutes until Dr. Elsamadicy comes back on. And I have to also go give a talk on connectomics here at the Barrow Neurologic Institute in Phoenix. So I wanted to just offer my availability. I'm here to answer questions. Anything from the week that stood out as really cool or something you didn't know, um, anything I can try to answer. Now is a good time. So someone asked, will robots ever replace surgeons entirely? Not entirely. I don't believe that, well, in brain anyway. I think that we are a long, long time from that being possible. I would say that prior to that, um, the question is, will we reduce disease to only existing in acute forms, in which case robots can probably do acute life-saving surgery. And that's the way I think about that. So if we figure out how to prevent glioblastomas from ever coming, then you never have to do a glioblastoma surgery ever again. But in case someone forgot to get their screening or whatever and one shows up, can the robot biopsy it, decompress the brain well enough, and get you to a diagnosis and treatment? That's where I think the future of that lies. And I think those things are going to kind of evolve in tandem, and I don't know the answer. BCI in neurosurgery is very cool. BCI is brain computer interface for those of you who don't know. And I think that it's a lot of hype right now. I think I'm actually here in Phoenix where they work with Neuralink, and they're able to put these electrodes in, but they're worried more about just getting it to market than they are necessarily about what it's going to do. And the potential is huge. But there's hiccups. There's a lot of hiccups. The brain's developed scar tissue. They're only putting these electrodes in one region. What I would say is understanding those brain networks, which is the research obviously my group and I do, um, is a lot more important because then you can target better or augment it in different ways. The best BCI that currently exists, so Neuralink is obviously a big one. There's a stentrode, which goes in through vessels. There's a company called Precision, which makes an electrode that's really amazing at this. We've been able to play Pong with our brain for years, right? There hasn't been a major advance in this. There's just a Nature Medicine paper about, I think, moving some body parts with an implant that came out of Northwell, which is pretty impressive. And Chad Bouton, the guy who does it, is an amazing guy who's been studying spinal cord injury for years, and he's made huge progress. It's still pretty far away. If you want to see what BCI looks like actively right now, I think the closest is something like Vivistim, which is a vagal nerve stimulator. Vivistim is a surgery where we attach a vagal nerve stimulator. Vagal nerve stimulation actually has incredible systemic effects, both in reduction in inflammation as well as inducing neuroplasticity. And so that starts to speak towards a time where if we can, maybe without surgery, hopefully, we can stimulate certain components to induce plasticity. If I want to learn a new language, maybe I just got to stimulate my neck a little bit before I study it. And I think that's probably an earlier next step, or neurorehabilitation, right? If I know what networks I've injured, can I augment the compensatory networks in an intentional way? That's where I see that. So this is a great question. As a med student, how do I educate myself to be AI compatible during my practice? I think this is actually probably the single most important question for you guys during this session because this is real. It's happening. People are obsessed, and it's moving on beyond answer my question to AI developed systems. And so what I will say is use it. Do not be afraid of it. Do not use it exclusively. Use it as a collaborator. And the goal is to find out how to use AI in a way where you're still in control, where you're still the leader of how you're using it and how to help it augment you. And if you're doing it that way, rather than just relying and throwing all into it, I think that's the best approach to dealing with it. You have to stay educated on this. I think that it's very, I have it's actually funny. I have a chat GPT um, weekly message. They have these abilities to kind of do repeated actions. And so it gives me AI updates on Thursday mornings. And it is the most overwhelming message I get weekly because all I do is I say, oh my God, like everything I've ever thought of is already thought of and already been brought to a business. And I can't keep up. And I don't know how, this field is moving so fast. Um, so much of that is hype. So much of that is the way that investment works is just creating hype and generating hype. What I think you need to understand is just how to use it in your own life in a meaningful way and how to not give yourself up completely to it, how to be a collaborator with it, how to have it help you be better. Because I think there's a lot of opportunity for that without a doubt. What else here? Um, would extended reality be an important asset in cases of emergency surgery? Less so in emergency. Nothing's really important in emergency surgery. Just getting the surgery done is important. But sometimes, um, do I envision AI being able to identify critical neurosurgical structures or neural structures? 100%. I think computer vision is the next level of this. It's extremely undertapped. And I actually think that we'll be able to ultimately get rid of navigation as we know it and just use surface imaging of brain material, and the AI will probably learn it. But that takes a lot of work. In order for computer vision algorithms to learn this stuff, you need someone to annotate it. So for instance, I'm here with Mike Lawton. Mike Lawton has countless videos of how he clips an aneurysm. Those videos are incredibly valuable to anyone trying to build a robot. Learning how the tissue deforms, learning the anatomy, learning what step he does first. Over 1,000 cases teaches a robot how to do that case. Um, but someone has to sit down with that video and annotate every single step of that so that the computer can learn it. So we're a long ways away, without a doubt. Um, what else? Understanding the blood-brain barrier, integrating AI increasingly important. I will tell you, increase integrating AI is hugely important. I will challenge your blood-brain barrier notion because we have drugs for lung cancer like Tagrisso, which don't give a shit about the blood-brain barrier. So I would say that understanding the molecular biology behind the disease and figuring out how to treat the disease is much more important. In the current setting, yeah, people like me with gray beards need to figure out the blood-brain barrier for now, but I'm not sure you guys need to. What else? Are hallucinations a problem for AI in healthcare? Sure. If you let the AI make all your decisions, then you deserve the hallucination. Don't do that. Like I just said, collaborate with it. Understand how to make it make you better. To do that, you have to have information. Um, what else? What else? What else? Harsh environmental impacts of AI. It's a great question. Um, I don't have an answer for that. There are harsh environmental impacts of eating beef. All right. There's harsh environmental impacts of driving a car. I think that this gets down to kind of an existential means versus ends question, which is ultimately kind of a chicken and egg. I think that if you were going to use it in anything, I think using it to help people makes a lot of sense. Um, makes a hell of a lot more sense to me than war, right? Um, but I don't think you or me are going to make those decisions. I think we have to be aware of them because obviously, as groups of people, we have powers to change things. So I think just be vigilant, understand what it is you're dealing with, be intentional with your use. Um, but yeah, I think that's a very great question. It's a very difficult question to answer, other than just be a good person. What else? AI transform interventional neuroradiology. I think there's a huge opportunity here. Um, Mainly because in interventional neuroradiology, so much of what we do is kind of hidden. Sorry, I'm tying my shoe. Um, because I have to go downstairs in a minute. Uh, you know, from an extended reality standpoint, there's a very big opportunity. We work right now, and I've said this before, we fix brain problems from about 3.5 feet away, um, through a needle in your groin while looking at a computer screen. It's insane, right? It's such an incredible field. Um, Anything like that where you're not physically touching the object that you're treating, I think both extended reality, I think both artificial intelligence, all of these things can help out tremendously, because you're really just working with a model anyway, right? Um, and so if you're coiling an aneurysm on a radiology on a screen on an X-ray screen, um, I think that your two fingers twirling a catheter are no better than an AI telling you what size coil to use, reproducing the 3D volumes, telling you over the last 3,000 cases, people did better if you did this. I think all that exists or will exist. How can nurses and medical assistants, et cetera, learn to collaborate with AI to get the most out of it? Yeah, I don't think there's any difference. I think that it comes down to, like I said before, having something that's immediately accessible and contextual, that can make you smarter or better or faster at what you do. And so I think, you know, just use it to solve a problem. Identify a problem, think about what the solution to that problem would be. And if you don't know, you can ask your AI assistant of whatever sort. Um, but go a step or two deeper and see, um, what are the pitfalls of that? What are the possible applications of that? What's another way to do it? Um, what I really like about all of these large language models is the conversational nature of it, where you can push back a little bit and you can push to that next level and test your own hypotheses, and keep going. Because I think there's an engagement component that's a hell of a lot better than tapping a heart on someone's Instagram. Um, and I think it produces, interesting cognition and whatnot. All right, guys, I see Dr. Elsamadicy has joined. I want to thank him again personally for coming on yesterday and for being available again for you guys today. Like I said, I think it's going to be a great course. Thank you all, everyone who signed in today, and for the whole week. Like I said, I've heard it's been a fantastic course. The people we got to teach are really committed to this. I think it's another successful year, and I'm looking forward to next year. And have a great afternoon, have a great day, have a great weekend, and take it away, Aladdin.
Thank you, Randy. And have a
Take
good
care,
one. I know
guys.
you're in Phoenix, so
I'm going
safe
to give it.
travels.
Thanks. I'm going to give a talk at the Barrow now. So I'll see you guys later.
Nice.
Bye bye.
Take care. Um, so, Samantha, hey everybody. So I'm happy to introduce Adam, Samantha, if you want, or I know we send over the link and so forth.
Yeah, hi, how are you? It's good to see you again. Thanks for coming back. Everyone, we have Dr. Elsa Medici back with us again this morning. In case you need a refresher, he's a neurosurgeon with Northwell who specializes in complex spine surgery. And he's joined this morning by Dr. Kundishora, a pediatric neurosurgeon at the Children's Hospital of Philadelphia and an assistant professor of neurosurgery at the University of Pennsylvania. He has specialized training in both pediatric neurosurgery and pediatric spinal deformity. So we're very grateful that the two of them are taking time out of their. Dr. D'Amico said you're on a road trip this morning to speak with
Yeah.
us and answer some more of our questions. So thank you guys so much for being here.
Thank you guys. Yeah, we had such a great session yesterday. And when there was an opening for this morning, I talked to Dr. D'Amico and we were like, you know what, because you guys had so many good questions, and we couldn't get to everything, that we kind of just said, you know what, let's just go ahead and make this a Q&A. And we have one of my really good friends here who's way far talented than I am. And he does a lot in Philadelphia, especially with mentorship and so forth. So I figured it'll be a good treat for this opportunity. So I would say I'm going to let Dr. Kundishora start speaking, and then I will kind of man the chat as you guys put in questions, and then we'll kind of do what we did last time. And I think, Samantha, what I'll try to do is I'll try to log on from my phone as well. So but I'm gonna hold on to the phone, but I'm gonna give it away to Dr. Kundishora.
Hey guys, how's it going? I'm Adam Kundishora. I'm a pediatric neurosurgeon at CHOP, as you heard. I did a couple fellowships, one at the Shriners Hospital for Children in Philadelphia in pediatric spine deformity, the other at Children's Hospital of Philadelphia in pediatric neurosurgery. And so Aladine and I, we actually trained together. We trained together at Yale. And, I think whenever I have a session like this where I'm talking to, excited, young people on the beginning of their path here of neurosurgery, I always start with the same thing, which is to say that, this is a journey. This is a long journey, and it's an amazing journey. You meet a lot of people, you meet a lot of mentors and mentees along the way, as evidenced by the fact that here we are. Aladine works in New York, I work in Philadelphia, but we managed to get together this weekend. And I find so often from my students at every level, whether it's high school, undergrad, college, grad students doing their PhDs, residents, that there's an intense focus on the destination. And I think it's appropriate because you have to have your eye on the prize, but recognizing that the destination is far away, and this shouldn't be intimidating, but it is far away. My personal training journey was 17 years, including undergrad. So that's that's okay. So that's 4 years of undergrad. I actually had a short stint in public health for a while, and then 4 years of medical school and HHMI fellowship, 7 years of residency, 2 fellowships, so 17 in total. And about halfway through, I think I realized that I was probably a little over focused on the destination, and I was missing the moment sometimes. So what I love to tell my students, my mentees, and frankly to tell myself, is that destination always moves ahead of you. Once you reach that next level, you're going to see another finish line X number of years in the future. And so don't worry about that. Keep running towards it. Don't worry about it. But dig into what is happening now. A lot of you guys on this chat are doing just that. You're enthusiastic and you're trying to soak up information about the field and about the path. But it goes even farther. When you're in your undergrad classes, throw yourselves into that 100%. Don't be afraid of taking risks. And when an opportunity comes your way, the default answer should be yes. Now managing your bandwidth and managing your ability to split yourself between certain things, but the default answer should be yes, because the more you expose yourself to and the more you throw yourself into the now, the more that this journey won't just be something that you're going through to get to the ultimate goal, but it will actually become an incredibly enjoyable, fulfilling life path. And I think, there's a lot of talk about these things like burnout and all this. And I think a lot of it has to do with not appreciating where you're at in the moment and having enthusiasm for the goal rather than having enthusiasm for the process. So that's just my little preamble. And whatever questions you guys have, I'd be happy to answer. Aladine, you have anything to throw in there?
Yeah, definitely. If you have questions coming through the chat, that's why I logged on to my phone so I can man the chat and be the cameraman as well.
We can.
But as we wait to see if any of you guys have questions, one thing I'll ask Adam is, what do you think? What would you tell, undergrads and med students who want to do neurosurgery, and they hear about the training and they hear about it's a long process and is it really worth it? What would you say about that in terms of some of these commentaries that they hear?
It's definitely worth it if it fulfills you. And I think that's something that you figure out along the way. It's hard work, but working hard is very fulfilling. Um, it's a lot of dedication. It's a lot of developing these sort of habits, that get you through the day, get you through the years. But again, for a certain subset of the population, that's a very fulfilling process. So as you go through this, if you find that you're energized by developing these habits, developing the skill set, by the discipline, and you're also energized, sustainable, it can't be all destination because that's so far away. You have to be fulfilled by the process. You have to wake up every day and be proud and excited to be working towards something. And that's what I think sustains people throughout that long journey.
Awesome. We have a few questions coming through the chat. So throughout your training, what experiences consistently remind you of basically why you chose neurosurgery? What still fills your cup after all these years in training and in practice?
You want to take that one?
So I think I touched a little bit upon it yesterday. I think for me is this you're running a marathon, and as you continue to run, there are things that allow you to keep running. And at least for me at this stage which is both the most frightening plus also the most rewarding, is the accountability that you have for patient care. The decisions we make, we have these decisions. These are our decisions that we're making with our patients, and we're intervening on patient care, and the trust that a patient has that says, okay, I'm going to go to sleep and now you're going to operate on my body to for that trust and process for me still keeps me up at night, but also is what fills my cup.
I agree 1,000%. It's the interaction with the patients and the impact that you have on their lives and the responsibility for their lives. I actually do something for both myself and for my trainees and my whole staff. As an attending, we're very privileged to have this ongoing longitudinal, frankly, intimate relationship with our patients. It happens a lot in clinic, and a lot of my team, whether it's my residents, my students, my people in lab, they don't get that as much, and I recognize that. So I have everyone that I can sign a media consent in clinic so that I can take pictures and little videos and stuff like that. And I usually will play those videos, or I'll show those pictures at the beginning of things like lab meeting, or at the beginning of let's say we're going to do a case conference with the residents, as a reminder that the reason why we're doing this, we're having the long hours in lab, we're going through case conference, is the patient. And so, like a short story about that just recently. So my practice is split about 50-50. Half of it is pediatric spine deformity, and the other half is open cerebrovascular. And so just recently, I had a young girl who came to me with like a recurrent AVM, and she was really scared. She's 12 years old, and I resected the AVM, the recurrence, and it went really, really well. Now, she had experienced a couple of intraoperative seizures, which is not uncommon for AVMs. Let me just change lanes here, just 1 second. And so, we had her on video EEG monitoring afterwards in the ICU. And so what happened was she was on this video EEG, and so this was all captured. Because of that, I came into her room, and she was a little groggy after surgery, and I told her, "Hey, sweetie, your AVM is all gone." And she burst out into tears. And at first I was a little confused. And I said, "What's wrong? Are you sad?" And she kind of shook her head no. And then I said, "Are you happy?" And she shook her head yes. And she asked me to give her a hug because the burden of having that AVM was impacting her day to day so much. And we forget when we're going through this process, like, you get beat down by the long hours, but the impact that you have on people's lives is immeasurable. And so, I take those little videos. I played that one at our last lab meeting, which was yesterday. And it just set the tone where now, whether it's that extra hour you got to spend on that experiment to get it right, or whether it's that, extra 30 minutes you got to spend in that difficult patient's room, why you're doing it. It's all about the why. So that's really what fills my cup, and look for ways to interact with those people and those patients so that you can fill your cup.
And along those same lines, we got a question about, could you elaborate on the hard work in what way? When I hear hard work, I think of working on a farm and cleaning, respectfully. I love to understand that better.
So it's not that different, actually. It's not that different from working on a farm, from cleaning, from any sort of hard work, I would say. There are two types. There are two types of discipline that I think embody this idea of hard work, or a lot of people refer to it as the grind. The first type of discipline is traditionally what you think of when you hear discipline. Wake up at a certain time, keep a certain schedule, make sure you have your tasks done, your organization. So that's all part of it. But the other type of discipline is what I refer to as cognitive discipline. So, pushing yourself to think in a certain way, to be insightful into your own state of mind and control that state of mind. To, one of my favorite books is Mamba Mentality, Kobe Bryant, to not negotiate with yourself. You don't negotiate with yourself. You set the goal and you tell yourself, I am going to get this task done. Not I have to, not I need to, I'm going to. It's not a negotiation. And then you hold that cognitive discipline to not allow the mind to wander off and make an excuse for why not, right? And the same thing comes when you're learning information. You say, I am going to learn this, not I'm going to try, not I have to, but I'm going to. And you set that mindset so that when you come up against challenge and you say, man, that test was really hard, I'm not getting it. It's not a negotiation. Oh, I guess it's not working out. No. I am going to get it, and I'm going to do as much as it takes to get there, to understand whatever concept it is that I'm trying to sort of wrap my head around. So the work is really embodied by traditional discipline and cognitive discipline over a long period of time.
That's a very good answer, and I think you said it the best way. So the next one is, thank you for taking time to talk with us. Would you tell us a little bit more about how to approach observerships in neurosurgery? Do you have tips on how to leave a good impression on your attendings, etc.?
I definitely have tips. And it's funny. I got to be careful because I think one of the biggest, one of my biggest pieces of advice, I don't want it to be taken the wrong way, but the word shadow is very specific. So when you go to shadow somebody, what is a shadow? A shadow is a projection of a person, but the shadow doesn't take up space. The shadow doesn't get in the way. The shadow moves around all the other objects. It's not thought about. Now, I am not saying that you should try to be invisible when you do a shadow or an observership, but I will say that there is a drive to be overly enthusiastic, and it's so important to remember that when you enter an environment where everybody is focused on a single goal, which is to keep a patient safe, you have to be careful not to try to draw too much attention away from that goal and put the spotlight on yourself and make you the goal of the room. Oh, teach me this. I have this question. I have that question. A lot of shadowing opportunities should be approached with a respectful introduction and a very short 1 to 2 sentence blurbs about who you are and why you're there, an expression of gratitude for being there, and then really stepping back and taking it all in and learning from the environment, not constant questions, not constant conversation. And then when the opportunity allows, which is often at the end, especially in an operating room setting, at the end of the case, when you see everybody's shoulders relax and now we're closing the wound, or the attending scrubs out and kind of makes eye contact with you and says, what do you think? Then the opportunity is there to say, hey, I really enjoyed that. There are a few things that I saw. Do you mind if I ask you a couple questions about it? That makes such a huge impact on me when I see a mentee do that, because it tells me right away that the person has a high EQ. They understand that the situation is not focused on them, it's focused on the patient. And that's the type of person who's actually going to do really well in the long term, because again, that cognitive thing, and by having the wherewithal to just sort of be part of the environment, but not draw the attention too much towards themselves. So you don't want to be invisible, but you do want to recognize what the goal of the room is and not try to take that over as an observer.
And then to add to that, there's things that you can control and there are things you can't control. Things that you can control is learning about the patient, learning about their pathology, reading on anatomy, reading on, so if you're going to go to a surgical case, if you go in with the mindset of, the residents are going to teach me, I'm not going to put the work in up front and come in prepared because I'm going to learn everything there. I take that as like the wrong idea. I like it when, at least me personally, when med students, because it's a journey. You're not expected to know everything, but there is an expectation of effort. So that you are making an effort to want to learn about what you're about to do. Especially when we are about to operate on someone. It's this mindset, it's a sacred position we're in. It's important for us to do the respect of understanding what's going on, but you don't have to know the answers. So that's where I think that it becomes a big thing where some of the people who observe, they're like, I need to impress, show them I know my stuff, or I need to show them. And what Adam alluded to about understanding the environment, understanding what everyone's role is very important. And sometimes not doing anything is the best thing, So I would say, at least for me, there's a lot of tricks of the trade. You learn as you go. You learn what works for you. But, putting effort in doesn't go unnoticed. And I think that's like the biggest tip, at least from my standpoint.
I want to say one more thing about that too, because you reminded me of something. A lot of times a mentee or something will ask me a question, as they should. But the quality of the question says so much about, I think, the quality of the individual. And when I started training, like, I'm not that old, like we all had cell phones, obviously, but the truth is we mostly had beepers. Internet was much slower. I mean, like, seriously, when I started, like, you couldn't load a video on your phone in under a couple minutes. So this idea that you had the compendium of the world's knowledge in your hand, you did, but it wasn't real-time accessible. You guys now do. And I mean, I heard earlier a couple comments about AI. I heavily utilize AI in my lab. So I've got a whole arm of my lab, which is AI driven. So, there are some really good resources where you can look these things up. It is at the point now where if you ask a question that can be looked up, I think it says more about you than you might realize. Never ask a question that can be looked up. In fact, when you're observing, you should be furiously looking things up as you're in the environment. Surgeon says something, you don't know what it is, look it up. They make a comment about, some management decision, open up your open evidence app, which is, an LLM trained on peer-reviewed literature, and look it up. You should be asking questions that drive at understanding, right? Those are the type of questions that show me that someone's on the next level. So, and then again, in that period after shadowing, when things kind of calm down, there's that chance to say, hey, Dr. So-and-so, do you mind if I ask you a question? Sure. Yeah, you mentioned earlier that it was really important that we preserve the draining vein of the AVM, and I kind of looked it up. I understand that the steps of taking an AVM are X, Y, and Z, but in this patient, I saw you like attack that vein early, and I'm trying to understand, like, when do you know it's safe to take the draining vein exactly? And I get a question like that. I'm like, that person is switched on. Not just like, hey, what are the steps of taking out of an AVM? Just look it up.
Awesome. The next question, I'll kind of summarize it. Basically, is how do you avoid burnout as a med student or an undergrad? You're doing a lot of studying and you're doing a lot of stuff. What advice would you have on avoiding burnout?
So in 2012, I saw a lecture. I was at Yale, and I saw a lecture that was delivered by a guy named Dr. Doolittle. That was his name, Dr. Doolittle. He was a doctor of internal medicine, but he also had a doctorate in. He had an MDiv. He went to the divinity school, and he studied different religions. So he was like a polymath. He had a great view on the world. He ran a study trying to answer this question. Had a huge impact on me. He looked for what causes burnout. Massive study, thousands and thousands of people. He looked at, do they exercise? What about the diet? Do they have a partner in life? Had they undergone some sort of big change, like a tragedy? Had a family member passed away? All these things. None of the things that you would think are associated with burnout were associated with burnout. It wasn't diet, it wasn't sleep, it wasn't relationship status, it wasn't any of those things. There were only two things that were protective against burnout in his study. The first one was humility. So people that scored high on the humility index, which is to say, people that didn't think that they knew it all, people that understood that the world had something to give them just as much as they had something to give the world, they were protected from burnout. I imagine it's because you start every day with the second thing that was protected against burnout, and that was gratitude. So people that scored high on the gratitude index were protected from burnout because you were waking up every day and appreciating the opportunities that were in front of them. Humility and gratitude. Going back to cognitive discipline, these things are within our control. You can choose how you frame the day and how you wake up every day. And so if you wake up every day and you're like, why do I have to go to this stupid rotation? I already know this. You're not humble about it. You're not appreciative for the opportunity. The class or a phase life you think you can squeeze all the juice out of it. There's always an opportunity to learn something, even if it's only how to maintain a positive attitude when you're not getting enough from your environment. And you reframe it. Okay, well, we're 7 months into this class and I feel like this is a total waste of time. I suppose this is an opportunity to learn how to just sit with something that I can't control and maintain a positive attitude. That's what I'm going to focus on. Boom. Now you're humble. Now you're gracious. Now you're going to avoid burnout.
It was interesting, when I gave my talk yesterday, for the the team that was on it, my number 4 tip on success was humility goes a long way. So
We're
friends. It has been briefly. Yeah, hopefully that kind of helps with the burnout question there. So the question that we got about the unique culture of mentorship at Northwell, and if you're not part of Northwell as a med student, how do you get involved? I would say it is not Northwell. We do pride ourselves in creating environments, but so we did the same thing at Yale. Adam does the same thing at CHOP. So it's not. I wouldn't say it's a unique thing of Northwell. I do think there is more people who have been recruited to Northwell to bring this idea of mentorship more and more. But I don't think it's only unique to Northwell. So I don't want you to think that if you don't participate or get involved with Northwell, then none of these things can ever happen. And I would caution you from that. The best way to get involved is whatever gives you the best opportunity to be consistently involved. So if they're, your home department, if you don't have a home department, a local, neighboring university that has a department, those are the things in my mind that I would start first in terms of building consistency and seeking that mentorship. Because what you don't want to do is, you try to get mentored from across the country, and then it's like you're on different time zones, and then you're like busy with different things, but it's hard to communicate it, and then the consistency isn't there. So that's what I would say. I mean, we do a good job, and Dr. D'Amico does a great job in what he's done at Lenox Hill. I'm at the main hospital in Manhasset, and we have a lot of attendings there. So I think depending on what we kind of talked about yesterday, depending on what you're trying to achieve, there's a difference between having an advisor, a mentor, and a sponsor. All three of those different roles can be played by different people. But I'm sure, as I was saying yesterday, that by the end of the webinar, Dr. D'Amico, as all the speakers have put their emails, definitely don't hesitate. It never hurts to send an email, and if an opportunity opens, it opens. The next question: how would you suggest to present yourself? Just a quick question, Samantha. We only have 5 more minutes until the next.
You guys can go as long as you'd like. I don't believe that we have another speaker after you, so if you guys want to keep answering questions, feel free.
Okay, we can do another 15 minutes.
Yeah, I think we can definitely go until like 10:15 or so, at least.
Thank
So
you
how would
guys. We
you?
appreciate that.
No problem.
Yeah, absolutely, and hopefully, if this type of session gives good feedback, we might try to incorporate next year. Uh, so how would you suggest to present yourself as a competitive applicant in securing a residency spot at such a prestigious program and institutions, matching as an American IMG? Which I have a comment, I guess, about the American. So there's the foreign medical graduate, then there's the American IMG, which what I'm understanding from here is that you have a U.S. citizenship, but you did your training overseas, and you're trying to come back to America for training. I know recently, given and I mentored quite a bit of people recently, or some of my mentees who their green cards have been put on hold, and there's been a delay in a lot of these things. And I know some people who got into residency, but because of the green card and visa issues, I'm hoping things get better on that end. So I think from the logistic aspects, it's hard to kind of touch upon that. However, in terms of competitiveness, what it has routinely been has been research productivity, and your letters of recommendation and your board scores. That routinely has been the big three, one would say, and especially with IMGs or FMGs and so forth. But I will say more and more what we're seeing now, obviously we're going to hear from Dr. Kundishora about this as well, but at least from what I'm seeing being on the other side, is that the letters of recommendation is single-handedly the most important aspect of the application. I'm going to take the logistics out of it. So whether you're an IMD or not IMD, you're applying for residency, a commitment to neurosurgery and the letter of recommendation to us has been such a influential impact, has so much impact on how an applicant is viewed. So of all three things, a letter of rec can get you into programs, but it can also definitely keep you out of programs. So even if you have 50 papers and your board scores are very high and all your grades are good, but you don't have the social awareness and you didn't do well in your rotation and you have bad letters, no matter how good your application is, neurosurgery is such a small field, and it's very important to keep an understanding that these letter of recommendations is part of our way of knowing what people who we trust in the field view you about and who have worked with you for a month and or so. So those things, that's where the mentorship comes in. Those where, and so when we talk about prestigious universities and so forth, the way I look at it is, a lot of medical schools in America is pass fail, so whether you made a 71 or 99, you still get the same degree, which is a medical degree. So our is in neurosurgical training, and I know that name plays into that role, but even those quote unquote non-prestigious names are some of the best, neurosurgical programs in the country. But to get into a neurosurgery program in America is its own accomplishment. And so I would say, I wouldn't think about how do you match into a prestigious quote unquote program. Is how do we match into neurosurgery in America? And I think that the goal of matching to neurosurgery, knowing that it's a small field and knowing that everybody relies on each other to try to attract the right people for this field, because you can look good on paper, but if you don't do well in residency and you end up dropping out or it's not working out, then it becomes there's one less neurosurgeon that's entering the workforce. So that's what I would say in terms of the letters of recommendation being, I think, the most important thing.
Yeah, two things. So I totally agree with your point about neurosurgery programs. So being at Children's Hospital of Philadelphia, I actually I see residents across 4 different programs in Philadelphia. I have my home residents from the program. I have my residents from Thomas Jefferson University, incredibly prestigious program, one of the best. Thomas Jefferson, so there's a special tie there. So Penn Jefferson. I have residents from Temple, and I also have residents from Cooper in New Jersey. And what I will say is that there's a convergence of neurosurgical training. The difference in program quality within our field is so narrow compared to internal medicine, for example, because the field holds itself accountable. It's very, very small. So I totally agree with Aladine when it says you're neurosurgery. The other thing is that, anyone who's trying to match into neurosurgery, but especially if you're coming from an international background, you need a champion. And this is directly related to the letter of recommendation. But there are things outside the letter, a phone call, personal connection, that a champion can do for you that you cannot do for yourself. So what does it mean to have a champion? What it means is to find a mentor and recognize that responsibility to be a good mentee. So a good mentee is someone who gives that mentor the energy to mentor. Most people mentor. I know I mentor because somebody used the phrase fill your cup. I love that phrase. It fills my cup. But I'll tell you, when it's not going well, it doesn't fill my cup, it drains my cup. So I think it's going well when my mentee is energetic, engaged, consistent. Okay. They're there when they say they're going to be there. They do what they say they're going to do. They work at the top of their ability. And I know that person is pushing themselves. I'm not having to push them, but I would actually rather have to pull my mentees back and say, whoa, like, don't push so hard, than constantly be trying to push someone forward. And then when you get a champion, that person in the field is going to go to their buddies, say, hey, lad, listen, I got this amazing international grad, been working with me in lab, always punctual, high EQ. I really want you to take a look at him for your program. And that's the difference right there. So you got to have a champion. And it all relates back to being a good mentee.
Next, and just to add, I mean that I use the word sponsor, and I do think champion and sponsor
Same thing.
are synonymous there. Just so you guys know, we're all talking about the same. Okay, let's go on to the next. Let's just start. Can you tell us about your first mentors and your experiences as a student finding them? Or now, as an expert yourself, what makes you want to invest in the growth of a student and support them?
You want to start with that one?
Yeah, I would say
I think because it comes through mine, it only shows my screen.
Well, I just have two phones on me. So what I would say is so my mentor, I would tell you my biggest mentor, to get a little bit more into detail. My biggest mentor basically is he was a resident at Duke when I was a med student. I knew nothing about neurosurgery, but what happened from what I was talking about yesterday, how like the hard work meets opportunity, and then that's where success can kind of come. And so for me, I didn't know much about neurosurgery. I heard something about it, that there was this one guy who did quite a bit, had a good track record of mentoring students and publishing. And I reached out to him for 6 months with no response. And then it wasn't until my second year of med school where he responded and we met for the first time. And essentially, from the talk that I gave yesterday, you see those databases that I talked about, institutional databases. That was the first thing. It's like 300 patients, and it's going to take you hours and hours and hours. And I was on rotation, so I would do my rotation and then come back at night. And I spent all my weekends data collecting and everything like that. So it was, I spent a lot of time doing so. So I say all to say is that by putting the work in, he wanted to invest in my growth, because I could have easily been like, no, there's like way too much work, like not going to do this. And then I would have lost on what I think is the biggest opportunity that I had, not knowing at that time. And so the investment and understanding his mentorship was the buy-in process. The buy-in process is, I'm a neurosurgery resident, you're a medical student, you have time, I don't, but we both want it's a two-way street. You want to be mentored, I need some help in getting these projects going. And so he then taught me the process. And once I understood the process, then I was able to continue to grow the way I wanted to grow. So that was for my thing about mentorship. I would say that was my first true mentorship in neurosurgery, which was the most impactful because it was what kind of built the foundation of my research career, and going into residency and as an attending. But I would say, to answer that second question, is if a mentee is willing to put the work in and they're showing the effort and they're showing like, hey, I'm in, then we're all in, if that makes sense. But what you don't want to do is you don't want to be all in and now say, well, you need to be all in to a mentor and kind of have that, I don't want to use the word entitlement, but almost that entitlement. Like, oh, you said if I was going to work hard, then I expect you to do X, Y, Z. And know that that's not, you shouldn't have that expectation. But good mentor-mentee relationships is when both parties are going towards the same goal and you're able to help each other to do so.
Yeah, you said it best. It's a two-way street. Um, the emails that feel, I got a lot of emails about it, and the emails that feel like a burden, they say, hey, Dr. Kundishora, I'd really love to get your mentorship. Do you have time to meet? And they're very benign sounding, but my thought is like, oh, all right, let me see if I can find some time. The emails that I tend to actually respond to are the ones that say, hey, Dr. Kundishora, I'd love to make myself available to work towards whatever it is that you have going on. I'm particularly interested in whatever, X, Y, or Z. But whether you have case reports, clinical research, or translational research that you think I could add to your capacity, I'd love to do that. I'd also love to get your mentorship. Please let me know if you have anything that I can help with. It's a totally different approach, right? The first approach is, hey, I'm here. Can you give me something? The other approach is, hey, I'm here. I want to give you something. And that's what sparks, because you got to realize your audience, the busyness, the schedule, it never really changes. What we're driving somewhere now. Last guy's like giving a talking bear. We're always running around. So your audience's time is very stretched. And so while we all want a mentor, we need to do it in a way that actually builds capacity, our own capacity, fills our cup, but selfishly also builds our own capacity. And so you don't want to feel like you're drawing down and saying, give. You got, give me. You got to give something back, really.
Okay, we're going to do one more question, and then we're going to do our closing kind of statements and so forth, which we think will be very good. So Dr. Kundishora mentioned the Mamba mentality. For those of us who are just beginning to explore, any other books, podcasts, resources that each of you would recommend? And I'll let Dr. Kundishora talk because he reads more than me. That's one thing I'm trying to work on more. I will say, because my answer is going to be very short, but then the real answer is going to be Dr. Kundishora's. But the book that I read when I was applying to med school, which was, if I have to say, what was the first time I ever really heard about neurosurgery, was when I read Gifted Hands by Ben Carson. And it was such a rant. I don't know why I picked that book up. I don't know what it was, but I was applying to med school and I was like, you know what, let me read something about medicine. And coming from humble backgrounds, we both come from humble backgrounds. When you read that book and you learn about Dr. Carson and his journey into this field of neurosurgery and the passion that he had about it, that's what kind of like, oh, wow, this is a very interesting. They also made a movie, who stars Cuba Gooding Jr. as Dr. Carson of Gifted Hands. So I'm not the best to answer about all the other books, but I'll say that one book is an easy book, and it's something that you could probably relate to as you're reading it, and it can motivate you.
I agree. I love that book. I love that movie. It's an amazing movie. It's actually a hard movie to watch at some points, right? Because there's a lot of historical context about Carson being one of the first Black residents at the hospital and how he was treated. There are 1,000 books that detail the heroic journey, right? What is the heroic journey? For anyone who's doing a liberal arts degree, you got to take your literature A, literature B, whatever you call it. The heroic journey starts with a protagonist who usually has a conflict, and then they have to learn something or go through some trials and tribulations to overcome that conflict so that they resolve the broader point of the book, the point of the story, whether it's, Will Smith beating the aliens or whatever. There's a heroic journey. Any book, I actually think that I'm more motivated by books and literature outside of neurosurgery because the heroic journey is so palatable. It's so easy to wrap your head around. Any book that details someone who has to expand their own capacity to overcome a challenge. The pursuit, again, Will Smith, The Pursuit of Happiness, is fodder for your motivation. So you don't have to find it in neurosurgery. You don't have to go out there and look for books of neurosurgeons who did it, because it's all the same thing. Neurosurgery is for you if you love it, but you don't have to do it the way every other neurosurgeon did it. You just have to overcome and expand your own capacity in the way every hero of every novel overcomes something. And so find a story that captures you and dig into that character and embody the values of that heroic character, whatever it may be, and just use that. And there are millions of stories like this. It'll actually be more meaningful for you to read a story about a character you resonate with for whatever reason than to read all the autobiographies of all these neurosurgeons and try to be like them. You'll find motivation in the world around you.
And so what we'll do is I'll let Adam give some closing remarks, and I'll give some closing remarks, and we'll go from there.
Man, I didn't have any time to think about what I was going to say because you jumped into me first. No, I got it. I got this. It's very simple. Actually, it's very simple. This is exciting. I think either starting or being in the middle. I mean, even where I'm at now, I'm not at the end of anything. Like, as I said, the finish line keeps moving ahead and ahead. And so you're always in the middle of your own journey. It's very exciting. If it's not, right? If it's not, find something else that is exciting, you know? I never discourage anyone from doing neurosurgery. I think sometimes people say, like, oh, if you could imagine doing anything else, do anything else because neurosurgery is so hard. I'm like, no, that's a personal decision. But it really hinges on whether or not you feel invigorated by the things you're hearing from the other surgeons that you're looking to for advice, Aladine, myself, everybody who's been giving sessions. It's exciting. Lean into it. Get excited about it. Don't be shy about it. Get nerdy about it with your friends. Don't care what other people think about it. You know, if somebody says, oh, are you going to do that? That's crazy. Don't you want to do something else? You're going to be working all the time. Like, you know what? I don't care. I'm excited about it. I wake up every day excited about it, to be on this journey. Just lean into it. It's an amazing ride. It ends when it ends. Who knows? There is no end, right? And that's the point. So live in the moment. Wake up every day excited, maximize your opportunity, you know, just drink it all up, and it's going to be a great ride.
That was very well said. So I would say from my standpoint, I love doing things like this. And I was very happy that Dr. Pico, reached out for us to be a part of it. And I want to thank Adam for joining this. I know you guys will enjoy his process as well. The one thing I want to kind of stress upon that we talked about yesterday a little bit is that this journey is your journey. This is your career path. It's no one else's career path. And you will meet people along the way, your career path, that are either going to motivate you to continue, or they're going to try to demotivate you and obstruct you. And it's very important as you're navigating that there is not one path for everybody. And my path, Adam's path, all the speakers that you heard over this last week, we all took different paths. And what I always, when I was younger and I would see somebody, I'd be like, man, they have it all together. They have everything's working out for them. They're a neurosurgeon. They're doing this. They're doing this. But understand that that journey and what I kind of showed with like the publications of like how many years it took me to get to where I'm at with publications. It's the same thing with career, is that it's going to take you a process and growth to get to where you need to get to, and understand that everyone has challenges at every level. There's not going to be a level that you obtain that is not going to be challenging. So what I want to leave you off with is enjoy the moment that you're in now, and don't fall for the trap. And I'm a victim of this trap, which is, okay, let me just get into med school, then I can start enjoying myself. Oh no, let me get into residency. I gotta get into residency, and then I can like start living my life. No, no, no. Let me get into fellowship, and then I can, let me get into my attending job. Oh, let me pass my boards first, and then let me get into associate. And if you do this, you're gonna find yourself going through your whole career, not enjoying the moments and life passing you by. And we're both young, and obviously, it's a weekend, beautiful weather. We've been planning a trip XYZ. Allow your schedule to work for you versus always delaying things and canceling things because you're still going for the next step. You are going to miss a lot of things. Don't get me wrong. There's a lot of birthdays, a lot of weddings, a lot of family events through this journey, but cherish the moment and live the life of that moment, and not think about, okay, I'm going to start living my life after I go through it next, because you will always be working towards a goal, and it will be until the rest of your life. So that will be kind of my big thing. Continue being motivated, as Adam said, and continue working hard, and hopefully each year, if any of you guys, I know that we have some Northwell students on here. If you see us in the hospital, don't be shy to say hello. But even the non-Northwell and everybody, you can always send emails. The worst thing someone can say is like, hey, we don't have that much time. But stay motivated, and it's a beautiful journey. So thank you guys. We appreciate everything. And hopefully, we might have a round 2 next year. We'll see.
Thank you guys so much for taking the time this morning to talk with us and answer all of our questions. It was really amazing advice.